Number one, preparation. Number two, observation. And number three, conduct of delivery. The second stage is the time from the full cervical dilatation to the delivery of the baby. On average, it lasts 2 hours in the nulliparous and 1 hour in multiparous. It may last another hour or more if epidural analgesia or intense opioid sedation is used. For spontaneous delivery, women must supplement uterine contractions by expulsively bearing down. In the second stage, women should be attended constantly and fetal heart sounds should be checked continuously or after every contraction. Contraction may be monitored by the palpation or electronically. Management during the second stage. First sign of the second stage. Number one, urge to push experienced by the mother. Full dilatation of the cervix should be confirmed by the vaginal examination if the head is not visible. The woman will get an explosive reflex with each contraction and will generally take deep breath, hold it, and strain down. It is known as Valsalva maneuver. Women should be discouraged lying supine or semi-supine. Lying in the left lateral position and straightening are particularly effective options. Use of regional analgesia may interfere with the normal urge to push. Maternal and fetal monitoring during the second stage. Half-hourly documentation of frequency of the contractions, half-hourly blood pressure monitoring, temperature record 4 hourly, frequency of passing urine, vaginal examination early in active stage or in response to the woman's wishes after the abdominal palpation. Perform intermittent auscultation of the fetal heart rate immediately after a contraction for at least 1 minute or at least every 5 minutes. Palpate the woman's pulse every 15 minutes to differentiate between the two heartbeats. Then on full dilatation, patient shifted to the delivery table and the patient put in a thoracic position after cleaning, cleansing, create a sterile towel around the vaginal opening. Now the process of conducting the delivery started. Delivery of the head. Control the delivery of the head to prevent the laceration. Episiotomy if required. Episiotomy is an incision through the perineum made to enlarge the diameter of the vulval outlet and assist the birth. Ask the woman to give only small pushes with contraction as the baby head delivers. To control the birth of the head, place the fingers of hand against the body head to keep it flexed as is shown in the figure. Continue to gently support the perineum as the baby's head delivered as figure. Head is delivered by the extension. As the head emerges, the baby will turn to one side for easier passage of the shoulder through the birth canal. Note the time if possible. Allow the baby's head to turn spontaneously. After the head turns, place a hand on each side of the baby. Tell the woman to push gently with the next contraction. Reduce tears by delivering one shoulder at a time. Anterior shoulders should be delivered by the gentle downward retraction above the head and the posterior shoulder by elevating the head. After the delivery of the trunk, baby is delivered. First, baby contact of mother and baby and cord clamping. Immediate care of the newborn. After born, baby lies between the mother's legs. Baby will usually take first breath within the seconds. No need for immediate clamping of the cord. Nearly 80 ml of the blood will transfer from the placenta to the baby before cord pulsation ceases. Reduce the chances of neonatal anemia and iron deficiency. Oropharyngeal aspiration is only done if necessary. After clamping and cutting the cord, calculate the Apgar score at 1 minute and after 5 minutes. Immediate skin-to-skin contact between mother and baby as bonding promote the further release of oxytocin. Baby should be dry and covered with a warm blanket. Initiation of the breastfeeding first half hour of the life. Newborn measurements includes temperature, head circumference, and birth weight. First dose of vitamin K should be given. Now comes to the management of third stage of labor. It includes delivery of the placenta, examination of the placenta perineum, and repair of episiotomy. The third stage is interval between the delivery of the baby and complete expulsion of the placenta and membrane. Normal duration of this sign is 5 to 15 minutes. Separation of the placenta occurs due to number one, reduction of the volume of the uterus, and number two, uterine contractions and retractions. Sign of the placental separation. Lengthening of the cord, a small gush of blood from the placental bed, which normally stops quickly due to the retraction of the myometrial fibers. Rising of the uterine fundus to above the umbilicus, and number four, the fundus becomes hard and globular. Now comes to the active management of third stage. For active management administration, 10 international units of oxytocin by intramuscular injection with the birth of the anterior shoulder immediately after the birth of the baby and before the cord is clamped and cut. After administering oxytocin, clamp and cut the cord. Do not clamp the cord earlier than 1 minute from the birth of the baby unless there is concern about the integrity of the cord or the baby has a heart rate below 60 beats per minute that is not getting faster. Clamp the cord before 5 minutes in order to perform controlled cord traction as a part of the active management. After cutting the cord, use controlled cord traction. When contractions are felt, left hand should be moved suprapubically and the fundus elevated with the palm facing towards the mother. Right hand should grab the cord, use twisting motion. This is known as bended embryo maneuver. Perform controlled cord traction as a part of active management only after administration of oxytocin and the sign of separation of the placenta. Record the timing of the cord clamping in both active and physiological management. During the third stage of the labor, oxytocin and tranexamic and oxytocin and misoprostol is recommended for the prevention of the postpartum hemorrhage after the vaginal delivery.
आपने पहले ऑक्सीटोसिन का बता दिया.
Yes, sir. Intravenous oxytocin 10 international units immediately after the delivery of the neonate, after either anterior shoulder or whole body delivery, and before the delivery of the placenta is recommended. If oxytocin and tranexamic acid
ये कहाँ से आपने देखा, कहाँ से लिए, कौन सी?
से और उससे अच्छे कहाँ से कलेक्शन करते हैं.
तो ये उस चीज पे मैं थोड़ा सा टाइमिंग ऑफ ऑक्सीटोसिन की बात मैं करूंगा. चले आगे.
If oxytocin and tranexamic acid combination is chosen, intravenous tranexamic acid 1 gram in addition to the intravenous oxytocin 10 international units immediately after the delivery of the neonate and before placental delivery is recommended. If oxytocin and misoprostol combination is chosen, sublingual misoprostol 400 microgram in addition to the intravenous oxytocin 10 international units immediately after the delivery of the neonate is recommended. If there is no intravenous access or if in low resource setting, sublingual misoprostol 400 microgram and intramuscular oxytocin 10 international units are recommended. Repair of episiotomy. Suture as soon as possible after the delivery to avoid the bleeding and infection. Starts just above the apex. Use 3-layer technique, vagina mucosa, perineal muscle, and perineal skin. Synthetic observable visceral rapid begins to fall off 7 to 10 days post-operatively. For each layer, use loose, continuous, non-locking suturing. This will reduce pain and dyspareunia. Now comes to the management of fourth stage of the labor. It includes observe and check. The 2 hours after the delivery is critical period. Postpartum hemorrhage occurs due to the relaxation of the uterus. Observation include bleeding, blood pressure, and pulse. And check before discharging the patient from the delivery. Number 1, uterus, frequently to make sure it is firm and not relaxing. Remove any presence of the intrauterine blood clots. Clots interfere with the retraction and the normal hemostatic mechanism of the uterus. Number 2, introitus to see that there is no hemorrhage. Number 3, bladder should be empty because full bladder can also interfere with the uterine retraction. Baby breathing well and that the color and the tone are normal. Thank you.
Now, I actually requested Dr. Aisha to rush through her presentation because I also intend to share something with you. मैं शेयर करने लगा हूँ स्क्रीन. Right. Now, why? What is the importance of proper management of labor? You see, in underdeveloped countries and like Pakistan, maternal mortality is unacceptably high. Although now it is said that it is the maternal mortality ratio in Pakistan is around 1. Sometimes it is 176, sometimes it is 140 per 100,000 live births. But that is still much more than what it is in the developed countries where it is less than 10. Even in Sri Lanka, the maternal mortality ratio is much less. It's less than 30. And as this slide shows, that more than 1/3 of maternal deaths, half of stillbirths, and a quarter of neonatal deaths result from complications during labor and childbirth. During labor, I mean the first, second, and the third stage of labor. So 1/3 of maternal deaths, half of stillbirths, and a quarter of neonatal deaths. That is the importance of proper management of labor. And the second point is that the majority of these deaths, they occur in low source settings and are largely preventable through timely intervention and without a lot of technology, without a lot of uh, special things. And then we also need to realize that when we talk of management of labor, we should not only be concerned with management in a teaching hospital. Now, the tendency is that whenever we talk about it, we talk as if we would be managing all labors in a teaching hospital with who is the birth attendant? The doctors, the residents who have been trained in that. As a matter of fact, in the developed countries, the skilled birth attendant is someone who may be a paramedic, who may be a nurse midwife, and who may be even a professor of obstetrics and gynecology. So skilled birth attendance is something which is a special set of skills which prepare a person to deal with and manage the process of labor and take the women through that experience in a safe manner for the mother as well as for the baby. So that needs to be understood that it is not only medicalization of this physiological process that we should be overwhelmingly concerned with. It is something that we need to understand that this is something which happens spontaneously, and we should allow it to continue with that in that fashion as far as possible, but to be on the lookout for any departure from normal so that a timely intervention, as the last sentence says, can be carried out. The now, then the other importance is that those to attain those objectives which are written in the first, monitoring of labor and childbirth and early identification and treatment of complications are critical for prevention of adverse birth outcomes. Therefore, while you allow the process to go on at its pace, you have to monitor the progress, not only of the well-being of the mother, but also well-being of the fetus. And there are those methods by which you do that. And then if there is any departure from normal, then it should be identified as early as possible, and remedial steps which are required that may be taken. Now, improving the quality of care around the time of birth has been identified as the most impactful strategy for reducing stillbirths and maternal and newborn deaths compared with antenatal or postnatal care strategies. So therefore, that is the importance of labor management that we need to understand. And also, this is the time to reflect upon the value of life of a young woman in the whole family setup. And therefore, this is the time which, of course, and this is the process which happens in a physiological manner on its own, but it is fraught with a lot of dangers, potential danger, and we as professionals can make an impact upon this. Now, I will switch over to another, not this one, another presentation. This is the labor care guide. ये क्या हुआ? जरा देखिए।
Screen share दोबारा करो।
स्क्रीन शेयर को जरा मैं पहले स्टॉप शेयरिंग कर दिया मैंने, अब मैं दोबारा से करने लगा हूँ। दोबारा से किया। देखना चाह रहा हूँ। All right. This is a presentation which is not made by me. This is available on the net and you can have it. This is introduction of, as it says, WHO Labor Care Guide. Now, you would know that we will talk about partograph maybe if there is time today, but in a separate presentation as well. But partograph was started in mid-50s. And then there were improvements upon that. And I'm sure that all of you professionals who are preparing for examination or who are in training would know what partograph is. Even if we do not practice it, but still we know what partograph is. So it was developed in mid-50s. It was improved. Some improvements came about it in 1972 or 70s. And then finally, WHO finalized a partograph in 1994. And that was being practiced at various places with some changes which every department thought that they needed to make in that. And according to that, the labor was kind of cared for and it was plotted how labor is progressing. But in 2018, WHO again started working on it and then came up with the concept of not only partograph, but introduced a concept which is labeled as labor care guide. And they have produced quite a few small booklets in providing details about the various aspects of that. But labor care guide is especially a special or improved or the latest form of what is one large page of the various graphs which are used to monitor the fetal well-being as well as the progress of labor and well-being of the mother. I personally think that it is a useful tool and we need to understand that, and as far as possible we need to practice it. But before that, there are some aspects which we must take into consideration when we are talking of labor management. One is that when we as professionals, those who go for postgraduate examinations, they have or they ought to, or they are expected to have the best understanding of the process of labor and the management, etc., etc. But we must also realize that for every labor, there cannot be an FCPS or MRCOG doctor. They would be too short in supply for the large number of labors that occur. And then it has also been seen that it is not necessarily a postgraduate qualified obstetrician who is required to monitor and manage the labor. Specially trained persons or healthcare professionals, as I said, they are under the definition of skilled birth attendants. They can very well manage the labor. And in periphery, like in villages or in primary health center or in secondary health facilities also, most of the labors can be managed safely if the labor is managed in a proper fashion. Now, It is not only the medical management of labor, but human aspect of the care during the process of labor that is also uh, uh, important to look at and also cater for. Because we should not consider women in labor as women who are going through that process, and ultimately when the head makes its appearance at the introitus, we just assist in bringing out the baby. It is not really that. The concept of a proper care of labor is summarized in this chart. If you look at the essential physical resources and competent and motivated staff who would be utilizing those resources and managing the labor through these multiple points, probably 9 points, which is respectful labor and childbirth care. Now, it's important, respectful, irrespective of the social, financial status of the patient, whether it's a general ward patient or a private patient, etc. It has to be respectful. And if you really look at the conduct of labor in the teaching hospital labor rooms, ask yourself, are we providing respectful labor or childbirth care? Then women at that time of pain, etc., they need emotional support from a companion of choice. And what we do, we would push the attendants out. Even in private facilities, we don't allow someone to accompany the woman many a times in the process of normal labor. I'm not saying that if you have to utilize forceps or you do cesarean section, even then you don't have that at that time. But at the time when the woman is going through say latent phase or first stage, or even in the first stage, or even in the second stage, they need to have someone, if they would choose to, someone who can be of help, emotional support. And it can be a sister, it can be the husband, it can be someone, a friend, someone whom the woman chooses herself, and that is something which is expected to be decided at the time of during the antenatal course of checkups, and at the time when you finally brief the woman about the process of labor and all that. So would she choose a companion, which is important. Then effective communication by staff, that we need to communicate to the woman what is the process of labor, what is expected, because when they come over, if you take the case of a primary gravida, she doesn't know what will happen. She must have heard some stories, and she may be quite afraid of the whole process. She may be terrified of how much pain she is going to experience, and how the doctors are going to, or the staff is going to behave with them, and how is she going to be taken care of. So that needs to be, those fears and anxiety elements, they need to be allayed, and the process of labor is to be explained, and also reassurance to be given that it does not necessarily has to be painful experience, and adequate pain relief as the next step says that would be available. She will have someone to attend to her needs. So she'll not be left alone in that painful state. So pain relief strategies, you can discuss that beforehand in antenatal or during the early part of the labor, and that should be done. That is something which, if we are providing that kind of care, that is important, that we should be providing that. And then regular labor monitoring and its documentation, irrespective of where it is taking place. So this labor care guide, which has been devised by WHO now, this is something which can be done even in the primary healthcare facility. So this is common for primary care as well as tertiary level hospitals, that you have the same kind of that labor care guide on which you plot the progress of labor and the rest of the things. So regular labor monitoring, documentation of events, audit and feedback, etc. Oral fluid and food intake. We generally tend to stop every kind of oral intake and say that if needed, we'll give intravenous. But in most of the instances, it is going to be normal vaginal delivery. So why stop giving them? You can, of course, if she is vomiting, etc., that's a different matter. But in the latent phase of labor, or if, the active stage of labor, also, if she would want to have some sips of fluid or sips of juice or something, she can continue with that, or light food. Mobility in labor and birth position of choice. Now, these are things like Aisha said, that we put the patient in a lithotomy and all that, and I personally also do that. But now it is recommended that, number one, the woman should be allowed to move about so long as there is no contraindication for her to be immobilized or to be put onto the bed when the head is not engaged and the membranes are ruptured, etc., and you fear that there may be prolapse of the cord or something like that, or she has preeclampsia, or there is a high risk labor, or there is bleeding or some problem for which you would not want the woman to be up and about, and you would want her to remain in the bed. But otherwise, mobility is something which should not be restricted. The woman should be allowed if she wants to move about. And then the position of birth. Well, we need not have the woman in lithotomy position. If you really ask yourself, what is convenient for the obstetrician, and for us, it's the lithotomy position. The woman is kind of tied up, and then we have greater control on the birth of the baby, and that's why we put the woman in dorsal position. We are not tuned to that, but those people who are, doctors used to, and they still do, domiciliary deliveries. Domiciliary delivery is going to the woman's home and doing deliveries there. And general practitioners in UK used to do that. I have myself done a couple of domiciliary deliveries at home. Uh, uh, the wives of a couple of friends, doctor friends, whose wives I have delivered. I took the delivery set from the hospital. It still was medicalized in a fashion. And at that time, earlier on, it used to be said that it is good for doctors to be ambidextrous, which means that you can utilize your left hand or right hand to assess or do pelvic examination. And why was that considered to be an advantage? Because if the woman is so that the setting of furniture in a woman's house may be such that you may not have access like that. You may not be standing on the right side of the woman. And if it is like so, that kind of thing, that was about domiciliary deliveries. Now, those of us who were so tuned to delivery in lithotomy position in the hospital, how would we find ourselves if we come across a situation where we have to deliver someone? Let's say if you are on an aeroplane and you are an obstetrician and you are called upon, then there is a woman who is labor and going to deliver. I imagine that kind of scenario myself, and I find that I'd be quite awkward in doing it, because we do it all in such a controlled environment. So therefore, mobility in labor and birth position of choice. And I commented last time that one of my patients, she wanted to deliver in sajda position. She said that I do that, or those contraptions or railings made by which the woman would support herself, and she would deliver in a squatting position. So that is there. Then pre-established referral plan. This is important. If the woman is being cared for in a primary setting or a secondary care, and it is ascertained or it is considered that safe conduct of labor and delivery will not be advisable in that setting because of certain complications, because considered that the labor is getting prolonged, or there is the likelihood of cephalopelvic disproportion, or there is bleeding, or the fetal heart is going up or down, or there is the abnormality of blood pressure of the woman herself, then what would you do? Then from the primary health care, the woman has to be transported and shifted to the appropriate facility. So there should be a plan that if something like this happens, where to send the woman. So that is about primary and secondary places from where the referral plan should also be there. And continuity of care generally is considered, but in these, and continuity of care is that there is one person who is a skilled birth attendant, and that person would remain with the woman throughout her labor, and will not be, at the change of duties, it will not be handed over to that. That becomes inevitable actually, now handing over that in our hospital settings when the duty is 8 hours, and after 8 hours the person goes away and there is next one. So now imagine yourself that if you were being taken care of by one person and you establish a certain rapport with that person, and you have confidence, you are comfortable with that, and suddenly you find that that person is not available, now it is going to be someone else, and you are halfway down your labor. So that will be a little unsettling for the woman, and it also affect the decision making, because that new person who's come in may not know what the rate of cervical dilatation is and how the pains have been, etc., etc. So, if possible, or as far as possible, continuity of care should be there. So these are different 9 elements. We need to, not only from the examination point of view, but as a matter of fact, if we want to learn the art of obstetrics, if we want to perform care of a woman in labor. I have done it. I now may not do it like this, but when I was training, when I was senior registrar and in early part of my private practice, I used to be with the patient most of the time, do all her examinations, monitoring, etc. myself, and it used to be an extremely fulfilling experience. But you can have a team of your own. If a team is known, there are 3, 4 doctors or those. If they're all introduced to the woman, then of course that makes it easier for her. That makes it more convenient, more humane, and then respectful labor and childbirth care. Now, let's get on to what it outlines: recommendations on intrapartum care for a positive childbirth experience. Now, you see, do we really look at it that we ought to give the woman a positive childbirth experience? We just take it upon ourselves as a chore or as a medical issue or kind of situation that we have to deal with, and whether it's a positive or negative experience, we are not really concerned about that. It shouldn't really be that. We should involve ourselves in the care of the woman. Now we are, and I am also, and before that, Aisha was, we are referring to woman, woman, woman. Particularly those of you who would be taking MRCUG examination for that, for them, I would advise that you stop using the term woman and start using the term person. Now, because of transgenders, etc., etc., the term woman is not used anymore internationally, and it is the person that neither he or she, it will be they. They is used even for a singular. So, so the WHO recommendation on intrapartum care for a positive child birth experience for a person like that, and the labor care guide. This is the next generation partograph. ये सारी वो चीजें हैं जो कि वो रिकमेंडेशन इनकी बुकलेट्स वगैरह में दी गई हैं. Again, we talked about some of these things. Individualized, yes, of course, childbirth and woman-centered, no intervention without undue medicalization should not be carried out. So no intervention should be implemented without a clear medical indication. Unnecessary oxytocin, unnecessary misoprostol administration, etc. Only intervention that serves an immediate purpose and proven to be beneficial, clear objective about positive childbirth experience. And what is this? This is not very clear, but you can get a picture of that from the internet of this labor care guide. This is a complete document which helps you plot the progress monitoring and progress of the status of the baby as well as the status of the mother and the progress of labor. The details come in subsequent slides. So it helps you monitor and document, offer supportive care. It guides the persons in offering that throughout labor to ensure a positive experience, assist health personnel to promptly identify and address emerging labor complications. Because if when you are plotting it, the progress of labor on this, you would know that it is not going according to the standard norms, and where it is deviating from that, you can identify and then prevent unnecessary use of intervention, support, audit, and quality improvement. And these are यहाँ पे कहीं भी लिखा हुआ है, designed for the care of women and their babies during labor and birth, includes assessment, observation, on. However, the labor care guide was primarily designed to be used for the care of apparently healthy pregnant women and their babies, that is, women with low risk pregnancies. And high risk pregnancies may require additional and specialized monitoring. Of course, that was mentioned earlier on, that if there are those circumstances, then you would be taking. But this particular labor care guide has been designed to be used even in the, as I said earlier, in the primary health areas. Documentation of the labor should be initiated when the woman enters the active phase of the first stage of labor. Now, this is again a deviation or change from the previous notions or principles of labor management. From mid-50s, as I said, when the first partogram was designed by Emanuel Friedman, an American obstetrician. At that time, it was considered that up to a dilatation of 3 centimeters, it was latent phase. And after 3 centimeters, the active stage of labor started. But now, this latest labor care guide that would consider latent phase up to 5 centimeters, and only from then onwards starts the active state of labor. So that's one change. And the labor care guide actually has to be plotted from the time that there is 5 centimeters dilatation. And once initiated, the labor care guide will support continuous monitoring throughout the first and second stage of labor. Is designed for use at all levels of care and health facilities, although the plan of action will only vary depending upon level of care. Because if there is seen any complication getting developed during the course of labor, then of course the patient would be referred from a primary facility to an appropriate facility. Earlier identification of potential complications, and hence it should be timely referrals. Now, this is there are these 7 steps. This is the part which gives the identification information: patient's name, age, parity, etc., any risk factors. Number 2 is this area is the supportive care. Is there a companion? What about that? Yes, no, and how does the patient feel? There is detail which is going to come in the subsequent slides. Then third part is over here. This is care of the baby. This is the care of the mother or the woman. And this is the medications which are given. Or no, here you plot the progress of labor. Dilatation, cervical dilatation is plotted here. And the descent of the presenting part, which is the head normally, that is presented here. And then medication and shared decision making. This is something which generally we are not used to, shared decision making. We think whatever we say, whatever I say as a doctor or a specialist, I become God. This must be carried out. This is something which is non-negotiable. This is something which we cannot discuss. I will not alter that, and it must be like that. It is not. That is not the attitude. So it has to be a kind of shared decision making, in the sense that even if you are going to use a forceps, you tell the woman, explain to her that this is the situation. I need to use the forceps, and can I use the forceps? No, that kind of attitude. So it's a radical change of management plan that now we are faced with, but this is something which we need to do. This is an example of how it has been uh, a demonstration of how one particular labor has been plotted. Now, here it is given the details of this is the first part, which is the patient's identification. You see here name, parity, labor onset, active labor diagnosis, date and time, and the rupture of membranes, date and time, and risk factors. So this is something that this is the identification part of the uh, uh, labeling when it starts. In the top, every component here is topped with this alerts area, which is about the hours that have elapsed since the start of active phase of labor. So at the time, now this is about the supportive care, companion, pain relief, oral fluids, posture. No, yes, no, or whatever SP means, that supine posture. Or if she is up and about, you will mention that here, that at this time she was up and about, was standing here, the companion was available, pain relief was given in the form of whatever that can be, and oral fluids allowed or not. So this is the second component of, this is the third care of the baby, which is baseline fetal heart, which is between 110 and 160. And fetal heart rate deceleration, late, early, or normal, and amniotic fluid, meconium 1+, 2+, 3+, or B is for blood. And if it is normal, clear, that you would write clear. And fetal position, if the head is considered to be posterior or transverse, caput 1+, 2+, 3+, or molding of the head. So this is monitoring of the baby, and you go according to this level, 1 hour, 2 hour, 3 hour, whenever it is carried out, and then it is. And this is care of the woman, pulse between what is the rate, normally 120 and 60, systolic, diastolic blood pressure, temperature, urine for proteins and acetones. Whenever she passes urine, that should be tested. And here it is the progress of labor. This fifth component, contractions per 10 minutes, less than 2, more than 5, or it's 3 or 4 or whatever. So you write that number. Duration of contractions less than 20 seconds, more than 60 seconds. And then here is the cervix, 10 centimeters. You would put a cross over here, or 5 centimeters, or whatever number at whatever time it happens. And in this area is the position of the head. You plot it by 0, that it is -5 or 5, 4, 3, 2, 1, and then last of all it is 0. This is the medication, oxytocin, other medicine which may be given, or IV fluids, started at what time or given, etc. And this later part is, of course, about second stage of development. And this is the assessment and plan if there is departure from normal, so you write about that. So this is what it is, the WHO labor care guide. We'll stop here, and I will take any questions if you have. This is the presentation I'll share on the WhatsApp, and you can have it from the net as well. So I would recommend that you go through these. These are 2 voluminous booklets: WHO Labor Care Guide, Users Manual, Recommendations of Intrapartum Care for a Positive Childbirth Experience, or Intrapartum Care Recommendations, slide document, training slides, etc. It is worthwhile. But what happens actually is that during training, or particularly at this time, when many of the doctors in the audience might actually be preparing for their examination, one may find that this is too distracting, too elaborate, and may not be in the high priority of topics that one would want to. But if you want to be a good specialist, if you want to be a good obstetrician, I think that this is something that you need to adopt. You need to give time to and think about it, and understand that the process of labor is something which is very important, and half of our specialties work, or as a matter of fact, more than half of it is concerned with this. So therefore, it is important that we become uh, thoroughly familiar with this. We understand what is right, what is wrong, what is appropriate intervention, what is not, and how an inappropriate intervention can change the course of labor. So it is an important subject which will remain with an obstetrician for throughout their professional lives. And therefore, I would urge all of you, not only from the examination point of view, but from the point of view of being good specialists, that you must not only familiarize, but thoroughly understand it and practice it. Although we all will have to bring in a lot of attitudinal change in providing what is considered to be something, a basic right of woman. So, if there are any questions, please go ahead. You can put them on chat, or you can ask otherwise. Connection to the
Assalamualaikum, sir.
Walaikum.
सर मुझे पूछना ये था कि लेबर केयर गाइड में सेकंड स्टेज ऑफ लेबर में 15 मिनटली मॉनिटरिंग का कहा है, लेकिन जैसे हमारे पास है फैसिलिटीज की, मतलब 1-to-1 केयर नहीं होता, या लेबर रूम में एक डॉक्टर अवेलेबल है फॉर पेशेंट्स के लिए, तो ऐसी हालत में भी हमें 15 मिनट वाली मॉनिटरिंग दिखनी चाहिए।
Yes, actually, you see, I would consider that in labor room, in a teaching hospital or teaching facility, I wouldn't, if that is mismanagement, if there is only one doctor in a labor room. Because most of the teaching units have so many trainees these days. As a matter of fact, I would say there are excess number of trainees. I have managed myself a labor room on 24 hours basis. I remember I used to monitor the patients properly. So far as I remember, number one. Number two, it doesn't has to be necessarily a doctor. If you have staff nurses, if you have midwives along with you, you should train them, and they just have to hear the fetal heart, and not necessarily by a sonicate. And most of the units now have sonicate, so you don't have to really put the Penard's fetoscope on the woman's abdomen and count them by the watch. The sonicate gives you instant fetal heart. So you don't have to do it for half a minute. You can do it in 10 seconds. So that's number one. Number two, if it so happens that there are 3 or 4 women who are in labor and there is one doctor, I think that it will be a little overtaxed, no doubt about that. But still, you should make the best of it as far as possible. But I really fail to understand why in a facility where there are 3 or 4 or more laboring women, there would be only one doctor. So there should be more of the doctors on duty. Instead of doing 1 in 5, they should be doing 1 in 2 roster. Right? That is my answer actually. और बताइए आप क्या ऐसी कौन सी सिचुएशन है जहां पे सिर्फ एक डॉक्टर और 5 पेशेंट्स हैं? हमारी चैट खत्म हो गई।
सर हमारी फैसिलिटीज में अक्सर जो है एक या दो डॉक्टर्स होती हैं, और लेबर रूम में आपको पता है हाई रिस्क पेशेंट्स भी आते हैं, पोस्टमार्टम पीपीएच के साथ भी आती हैं, और वहीं अब मिसकैरेजेस की पेशेंट इनकम्प्लीट
आपका पॉइंट मैंने समझ लिया, लेकिन मुझे ये बताइए कि आपका जो डिपार्टमेंट है उसमें टोटल कितने रेजिडेंट्स हैं?
सर 11 से 12 फॉर 24 आवर्स।
11 से 12 और
जी जी।
नहीं, टोटल रेजिडेंट्स कितने हैं टोटल आपके यूनिट में?
टोटल
टोटल
सर,
टोटल रेजिडेंट्स
सर
कितने?
सर हाफ हाफ हमारा ग्रुप चलता है, मतलब वीक में 2
नहीं
डेज हमारे होते हैं, तो
नहीं,
मतलब
चलिए आप लेट्स से कि आपके आपके टोटल रेजिडेंट्स 40 के करीब हैं आपके यूनिट में।
सर 24 25 ऐसे, मतलब हाफ हाफ करके 2
नहीं
ग्रुप
नहीं,
चलाते
पहले पहले मुझे टोटल बताइए, टोटल कितने हैं, गायनी ऑफ सारा कुछ मिला के बताइए टोटल कितने हैं।
हैं। सर मैं अभी रेजिडेंट नहीं हूँ, मेरी ट्रेनिंग कंप्लीट हो गई है, तो अभी का मुझे नहीं पता,
नहीं, जब
लेकिन
आप ट्रेनिंग कर रहे थे तो उस यूनिट में कितने रेजिडेंट थे?
सर 36 35 ऐसे होते थे हम।
36 35। चले, आप आधे जो है 36 35 पे तो आए। आप उनमें से आधे जो है 18 या 20 आपने लगा लिए उस पर। अब 18-20 में से आप लगाएं 8-8 घंटे की ड्यूटी या 12-12 घंटे की ड्यूटी लगाएं, तो आराम से आप अगर 4 ग्रुप भी बना लेंगे तो उसमें भी 4-5 लोग तो हो जाएंगे। 4-5 लोग तो मेरे तो ख्याल में ये 36 बहुत ज्यादा है। व्हेन आई वाज प्रोफेसर और हमारे यूनिट में होते थे तो 2 से 3 डॉक्टर होते थे और सारा कुछ करते थे। So you take you see it is how you manage your workforce, जितने लोग हैं वो किस तरह से मैनेज करते हैं और कैसे चलाते हैं, so उसके ऊपर है। वो 1-to-1 केयर वाली वो बात कहीं पे भी है सच नहीं होती, लेकिन प्राइमरी फैसिलिटी पे फिर भी वो हो सकती है। प्राइमरी फैसिलिटी पे
सर वहाँ
वो
पे
एक आ गया बंदा तो एक ही पेशेंट लेबर में है वो हो गया। बट इन अ टीचिंग यूनिट यू देयर आर 2 डॉक्टर्स, देयर आर 3 से नर्सेज और मिडवाइफ्स, साथ में वो भी है, साथ में वो भी, तो उस तरीके से वो हो सकता है। और ये वाली चीज जो है ये एडमिनिस्ट्रेटिव या लॉजिस्टिक्स मैनेजमेंट का इशू है, तो वो हमें उस तरीके से वो भी मैनेज करना होगा, बिकॉज व्हेन यू आर लर्निंग दीज क्लिनिकल things, at the same time you also learn how to manage the logistics, your resources, and that includes the various hands that you have available, the doctors, the nurses, and how you are going to utilize that. So that also is part of our responsibilities. हाई रिस्क पेशेंट में ये पॉइंट, एक तो आप अंग्रेजी में लिखा करो, अंग्रेजी में उर्दू मत लिखें, आप सारे पढ़े लिखे हो, यू शुड बी एबल टू आस्क योर क्वेश्चन इन इंग्लिश। हाई रिस्क पेशेंट में ये पार्टोग्राफ एग्जाम का बताएंगे ऑफ कोर्स। high risk obviously it's different, you know, high risk pregnancy is something different, and during the course of my talk I have at least once I have mentioned that for high risk cases you may have to deviate from that, and you give extra attention to those patients, and you take into consideration that the type of risk that she has, and according to that you monitor. For example, there would be, if it's preeclampsia, you would have a patient on continuous monitoring instead of monitoring her fetal heart every 15 minutes, 30 minutes. तो वो उस तरीके से आप उसमें फर्क कर लोगे। और कोई पॉइंट? चलें अगली दफा I'll tell you something about the partograph history. हाँ, 2-3 चीजें हैं। एक आयशा तुम्हारा पॉइंट था जो तुमने कहा था कि ऑक्सीटोसिन देने का टाइमिंग क्या है। ऑक्सीटोसिन देने का टाइमिंग जनरली जो होता है वो होता है विद द बर्थ ऑफ द हेड और द एंटीरियर शोल्डर। अगर आपके पास हेल्प अवेलेबल है, यू गिव इट इंट्रावीनसली। इंट्रावीनसली जब आप देते हैं तो इंट्रावीनस इंजेक्शन को एक्ट करने में यूट्रस के ऊपर इट टेक्स 40 to 45 seconds. And the purpose of this giving oxytocin, or previously we used to give ergometrine, it was that when you gave it with the birth of the head or with the anterior shoulder, that in 40 to 45 seconds, it will start acting on the uterus, and the uterus will then contract. And when it contracts, it will kind of help in pushing the baby out, number one. Number two, also with that contraction, the placenta would get separated. So while you take care of the baby and take that half a minute to 1 minute to clamp its cord and cut it and hand over or lay it over the mother's abdomen and all that, by that time the placenta would have separated from the uterus, and the uterus would have been pushing it down because of that contraction, which is brought about by intravenous oxytocin or agometrine. And then you go ahead with that branded induce method to remove. This is known as active management of third stage. AMDSL, active management of third stage of labor. So this is how it goes along. Now, if you give it later on, if you give after the delivery of the baby, then it's probably, and sometimes it will be a little too late. You have delivered the baby, the uterus was quiescent or quiet for a little while, and then you gave that injection. It will take a minute or whatever time, or that those 45 seconds. By that time, the cervix would have start kind of closing down, and it would bring about uterine contraction, but also narrowing of the cervix. So the chances of retained placenta would become higher if you give it late. So either you give it at that time, or you then give when the placenta is getting delivered. It's normally it happens. Assalamu alaikum ji.
Walaikum salam. Yeah, Janab.
ठीक.
Before you leave, I've been with you for last 5 minutes or so only. मैं 2-3 कमेंट करना चाहूंगा. आप वर्कफोर्स, उसके असाइनमेंट और यूटिलाइजेशन, उसकी जब मैंने ज्वाइन किया उसकी बात कर रहे थे. तो बात ये इन बच्चियों को ये आप समझा दें, अगर अव्वल तो ये समझी हुई है खुद ही, कि इस 4 साल की ट्रेनिंग में ऑब्जेक्टिव ये है कि इनको सब स्किल्स आती हूँ. पॉसिबली 4 साल की ट्रेनिंग में इन्होंने मोस्ट ऑफ द कॉम्प्लिकेशंस फिजिकली क्लिनिकली देख ली हैं और उनकी मैनेजमेंट में हिस्सा लिया है. सुना नहीं है, हिस्सा लिया है. तो ये है ऑब्जेक्टिव 4 साल की ट्रेनिंग का. और ये है ऑब्जेक्टिव इनके क्या ऑब्जेक्टिव क्लिनिकल स्किल्स कहाँ तक ले जाने का. और बाद में क्योंकि FCPS बन जाती हैं तो फिर 90% चांस ये है कि वो इंडिपेंडेंट हो जाएंगी. बहुत कम है जो टीचिंग डिपार्टमेंट में जाके फर्दर इम्प्रूव करेंगी अपने स्किल्स. तो इसलिए मैं आपका किस्सा नहीं सुनाना चाहता बार बार. फर्रुख साहब ने जब गायनी डिपार्टमेंट ज्वाइन किया था, 1 साल उस वक्त इनको ग्रेजुएशन किए 3 साल हो गए. 1 साल इन्होंने 12 बाई 12 के कमरे में 24 घंटे 7 डेज ए वीक और 1 मिनट बाहर नहीं ये गुजारा था. That's why he is sitting there. That's why he has such name. That's why he's got such practice. क्योंकि अगर आपकी फाउंडेशन ठीक होंगी फिर उस पर बिल्डिंग सही बन जाती है. वरना टेढ़ी बिल्डिंग होती है तो ज्यादा हाइट तक नहीं जाती, वो नीचे नीचे रह जाती है. तो इसलिए मैंने ये कहना इसलिए जरूरी समझा. इस तरह का क्लास मोस्ट ऑफ द टीचिंग हॉस्पिटल्स, टीचिंग डिपार्टमेंट्स में नहीं दी जाती. वो एट बेस्ट तो कभी कभार प्रोफेसर साहब कह देते हैं चलो पोस्ट ग्रेजुएट्स के लिए ये क्लास ले लेते हैं, कभी कभार, नॉट सो रेगुलरली, नॉट सो फ्रीक्वेंट. और आपके पीछे बैठी हुई हैं 4 लड़कियां. कितनी लड़कियां बैठी हुई हैं वहां?
5,
जी
6, 7 है. आज
और हमारे इस अस्पताल में ट्रेनीज कितनी है? डेफिनेटली मोर देन 7। तो बाकी या सो रही हैं घर पे इसलिए नहीं आई, या वो पोज कर रही हैं कि मैं लेबर रूम में बिजी हूँ इसलिए नहीं आई। बाबा आने का फायदा तो आप लोगों को है। फरज साहब अगर ये क्लास ले रहे हैं अपना वक्त निकाल के, इतने प्यार से, मोहब्बत से, इन्हमाक से, आपके लिए है। इन्होंने इस क्लास लेके क्या निकालना अपने आप के लिए, और आप फायदा के लिए। और बिलीव इट फर्क, जो तू बोल रहा सी ना पीछे, मैं नहीं कहता कौन, एक लड़की अपने टेलीफोन से खेल रही थी इन साथ में। बाबा ये सब आपके लिए है। इस दरिया में से जितना पानी पी लो, जितना फायदा उठा लो, ये आपका है। दरिया को कोई फर्क नहीं पड़ता आप वहां खड़ी हैं क्या फायदा उठा रही हैं क्या नहीं कर रही। एक बात। दूसरी बात, आप ये एक्टिव मैनेजमेंट ऑफ थर्ड स्टेज, यार फर्क मैं की कहूँ है, ये बात यहाँ क्लासरूम में करने की है।
Something which should be there automatically और हो जानी चाहिए वैसे।
अगर इन्होंने कुछ वक्त लेबर रूम में गुजारा है, ये कॉन्सेप्ट एक्टिव क्या है, पैसिव क्या है, क्या होता है, बस यार गल छड़।
तो मैं एक्चुअली दैट्स व्हाट आई सेड अर्लियर कि हमारा जो मकसद है वो सिर्फ इम्तिहान पास करने वाली बात नहीं होनी चाहिए, क्योंकि ये लेबर की मैनेजमेंट की बात थी। मैंने कहा था कि जी ये आप हो सकता है ये आपके होराइजन पे बहुत ज्यादा प्रोमिनेंट ना हो कि लेबर मैनेजमेंट की बात थी यार, कि ये वो ना हो बिकॉज क्योंकि इम्तिहान में क्या पूछा जाएगा, बट दिस इज हाफ ऑफ आवर स्पेशलिटी। और इसको इस लिहाज से इसके बारे में अपने आप को, अपने स्किल्स डेवलप करने को, अपनी बाकी सारी चीजें करना वो बहुत जरूरी है। इट इज अ वेरी इंपॉर्टेंट सब्जेक्ट फ्रॉम दैट पॉइंट ऑफ व्यू। ठीक है जी, थैंक यू सर, थैंक यू। चलेंगे।